Hello, Dr. Mindaugas. How are you?
Hello, Kram. I'm fine, thank you.
Doing
Few
good?
busy days, but it's exciting.
How's the IDS experience for you so far?
Super busy. Yeah, but it's also the atmosphere is really good.
Yeah.
And so it's my second time here.
It's your second time.
Yeah, but I really start to feel it's not only the show, but also the seeing the old friends, making new connections, the community thing. It's amazing.
Right? It's my first time here. I think on the podcast I've said it like more than 10 times right now. It's my first time. It's my first time, so they get it.
Yes.
But it's
Just
really,
one more. Yeah, it's the first time.
There's one more. I have at least a couple more times. So the idea is not seriously like it's you get here and you obviously want to see the new technologies, but also there's a lot of networking and seeing old friends and seeing people that you haven't seen for a very long time, right?
Yeah, sure.
In this version of the IDS, is there something that you were looking forward to see or something that is interesting for you?
Nothing specific really.
Yeah.
What's interesting that right now we have so many information before the product is launched online.
Yeah.
It's very difficult to be super surprised by something new on the show.
I see.
So nothing serious. Like I said, it's a bit more about meeting people and doing workshops, lectures, things like this.
I see.
Yeah.
And you're lecturing for us today. You're in the speakers corner.
Yeah.
Going to, tomorrow. It's going to be tomorrow, right? Or
It's today.
today. Sorry.
Yeah.
Can you talk to us a little bit about the content of the lecture?
Okay, so like what it was maybe 3-4 years ago, GC asked me to write an article together about class 2 restorations done only with injectable composite. And this is how my journey started to actually using flowable composites as full direct posterior restoration, which usually it seems like a pretty dumb idea. Ask anyone, can you use flowables for like a definitive restoration on the occlusal, and everyone will say, oh no, it's not strong enough and it will wear and blah blah blah. So basically I want to show what's possible, what are the properties of the material that are important, what benefits we have using injectable compared to the paste composites, and just basically I guess making colleagues a bit more aware that it's really not the same as a flowable composite. So we have to kind of change the mindset.
So what's the difference?
Yeah, so basically when we think flowable is lightly filled, super flowable, so non-sculptable, let's say. And we think it's inferior material from the mechanical point of view. But if you look at the studies about injectable, you can start to notice that actually it's stronger. The filler content is quite high for a composite. And what I see in my follow-ups, which is for me even a bit more important than what I read in the articles, because I see the real life thing, is it doesn't wear as much. And the gloss retention is so much better compared to basically all the paste composites I tried in my practice. Add the fact that since it's not really, you cannot really model flowable. So you have to change the mindset how you apply it. And if you don't model it, then you save time on modeling. So in the end, you get kind of better mechanical properties and you spend less time with the patient. So it's a really win-win situation.
And in what cases do you think this material stands out, for example, as compared to conventional composites or flowables?
Yeah, so I guess you can use it as a base composite replacement pretty much anywhere. The only thing I would say users should be aware of, since it's a strong material, I find it tends to be a bit more brittle than conventional paste composite. So maybe the flexure is not the same. So I would say you have to be a bit more careful when you restore incisal edges or worn down canines, or restore proximal walls for, let's say, Broxer patients. You can expect some chipping happen a bit more often. Other than that, you can use it for all the other cases. So for injection molding technique, both the anteriors and worn down dentition for the posteriors. If the if the occlusion is balanced and you have enough thickness of the material, it really performs quite well.
I see. And you mentioned injection molding technique, like it's becoming very popular nowadays,
It is.
right?
Yeah.
What do you think makes this material good for this technique? Because I think many people use this material for this technique specifically.
Yeah. So I guess if we remember the time where we had to use heated composite for, let's say, vertical dimension increase to restore the worn dentition, it was quite difficult to control the amount of composite you need to add, and that could lead to underfill or overfill or problems with the excess composite. So using clear stents, so you actually see how much material you inject, and for that you really need a flowable. And so, but since we know that the surface properties are great, so again, it's a very nice situation to use it for. And I guess we kind of need to understand as dentists that we have a very limited skill set to actually restore the tooth back to the natural proportions and surface. So I'm pretty humble, so I know my limits. And I know I will never do as good anterior tooth as my technician can do a wax approach,
Yeah.
So instead of trying to be that, if I can copy something with a silicone, again, I'll have a better result and it will be much faster. Yeah. Okay, I'm a bit limited on the shades and, all the layers. But again, you have to be super skilled to have a good eye for layering and measuring the thicknesses and everything. So sometimes the monoshade approach for some patients, it's just much faster. It makes so much more sense.
I see. And I talked to a few people here, and then many people kind of mix and match composites to, see what works for them, basically, right? Yeah, so this is probably like also something that we have to keep in mind as dentists, right?
Yeah, so like I said, since I know the limitation of the material, so if I know it's brittle, then I would use it in combination with the paste composite where I know the load might be, excessive. So for proximal wall buildups, I would use snowplow technique with using injectable and heated accord composite. And then I would switch to Everix flow dentin for the dentin replacement and then injectable for the occlusal because it makes me faster. So it's like a win-win from both worlds.
Yeah. What you just mentioned right now, material selection is very important, and I think we are at this time kind of lucky, I guess, compared to
10, 20 years ago.
20 years ago,
completely.
like your options were a bit limited. Now you have various materials that you can use for various indications. So if I can ask you, like when a patient comes to you, how do you start, your material selection process? What's the thing that you go thinking of first?
Yeah, so it's really case dependent, and sometimes sometimes the financial situation kind of guides your choice. Other than that, usually I make the final decision when I already have the cavity open, so I can really see how much volume I need to restore, whether direct is really a good approach, or maybe we should talk about indirect. So in the beginning with the discussion with the patient, in the initial consult, I would talk about which teeth we can restore directly and which really needs indirect. But also, I could mention that some of the teeth are quite unknown. So if we need to let's say do a big MOD cavity, sometimes up front I might talk about possible need of ceramic onlay. Yeah.
And generally speaking, do you prefer direct or indirect treatments?
It's a tricky question. I ask this myself all the time. We all know that indirect should last much better.
Yeah.
But
stronger also, compared to the...
But I also see my follow-ups of direct. They don't look too bad as well. And most of the times when you do direct, you're still much less invasive. You don't have to, prep as much. Yeah. So I think it's a tricky choice, and I guess all of the clinicians, no matter if you're just restorative dentist or prosthodontist, you should know how to restore the teeth in both ways so you can provide the best solution for the patient.
And I think the trend right now, or at least the people I meet through GC, are very interested in MI approach, like basically minimum intervention to get the results they want, huh?
Yes, but whenever we think about minimum intervention, we need not to forget what is the goal, Yeah. It should never become a goal, the minimum intervention by itself. No. The goal is always to keep the tooth,
Exactly.
Yeah, so
it's just a means to an end, I guess.
Yes, but sometimes we kind of mix it up, and then we try to be minimally invasive and, then forgot about basic mechanic rules, leave undermined cuffs, the tooth breaks, and, then it really
then
backfires.
it's not really minimum. Then it's not really minimum intervention.
Yes, but sometimes we have this, wrong idea. So I think it's really important to emphasize that, I guess, the goal is always to provide a restoration for the patient that will last as long as possible.
Exactly.
Yeah. And if by that we need to prep less, then hooray. But if we really need to prep a bit more to have a better restoration, then we shouldn't be afraid to prep more.
Yeah, of course.
To gain the thickness or to cover the cusp. Yeah.
Earlier today, I was talking to Dr. Bora.
Okay.
And we were saying and having restorations that look good is very important. But before that, they have to function well and to last long.
Yeah.
And
it's the same.
Right? And if you're not preparing the tooth well, if you're not making sure that your restoration is sound, then you're basically not being minimally invasive. You're being, you're not creating a good restoration, right?
Okay, so I guess you're minimally invasive at that moment.
Yeah.
But looking at the whole patient experience in, let's say, a few years' time, you might need to redo the case, meaning prepping more, and then you're not minimally invasive anymore.
Exactly. Yeah. The whole thing is gone out the window.
Yes.
Okay, just as a last question to wrap it up, if there is a thing that you would like people to keep in mind when listening to your lectures or listening to this podcast, for example, a takeaway point, what would that be?
I guess the main message would be is I feel like we don't have we don't need to think about composite materials like we did 10 or 20 years ago, because even though it's still paste composite, even if it's still, flowable syringe, the content inside, the technology inside might have changed so much that the traditional rules might not apply. So I guess you don't have to be afraid of new technology. And sometimes you just have to, take a leap of faith and try it out and see how it works in your hands. And if it's working, it doesn't mean it. If it's flowable, it doesn't mean it will last less long. So you just have to keep your mind open to new possibilities.
I said last question, but now I have another question.
Okay, please. Yeah, I'm happy.
If you're trying a new material, what's a thing that you look for that will convince you to try this material instead of materials that already are working? Because dentists like to work with what they know, right?
Yes, of course.
Yeah.
Not my case. I like trying out
which is good
stuff.
for this, I guess.
I'm just like, okay, if I see the material or new technique and I like the idea, I will investigate further. So try to read on it, see if there are cases published, see if there are follow-ups. If I think it works, then of course I'll try it out for selected cases. And the moment when I decide whether the material, technique, or solution really works, when I see the case after a while, so I can see how it performs actually, not directly post-op, but after a while. So if I have a follow-up patient after a year or maybe two, and I see, okay, this really worked, then I will start using it more. I'm trying, so I like trying out new things, but I'm never going full in, so I'm still using my traditional tested methods. Mm-hmm. But when the patient came back and I can see that it actually performs better, then I'm slowly starting to switch it up and incorporating it more and more. So even still, I love using GUI for, occlusal restorations. but I'm still using paste composite like 50-50. So I still like paste. But I enjoy working with injectable as well. So never all eggs in one basket, you know.
Yeah.
I'm still playing around with both techniques.
Makes sense.
Yeah.
Thank you very much. Appreciate
No,
you.
it was a pleasure.
Yeah.
Thank you.